It can happen to literally anyone, at any time. A sudden, terrifying moment that just comes out of the blue. We're talking about a first seizure. And when it happens, you're left with a million questions, right? What was that? Does this mean I have epilepsy? What do we do now? Okay, let's take a deep breath, dive into this, and really demystify the journey from that single, scary event to a clear path forward.
You know, seizures and epilepsy aren't some new, modern ailment. Nope. They're actually one of the oldest neurological conditions we know of, with records going back thousands of years. For most of that time, they were completely wrapped up in mystery and fear. But today, thankfully, we can look at it all through a much clearer, scientific lens.
But even with all our modern science, as this recent quote shows, it's still an incredibly complex puzzle. There's so much we're still figuring out about the deepest workings of the brain. But, and this is the important part, while the scientists are chipping away at that conundrum, the path for actually diagnosing and managing the condition has become so much clearer. And that's the path we're going to walk down together.
So, first things first, what is actually happening inside the brain during a seizure? Let's just toss the complex neuroscience out the window for a second, because the best way to get it is with a really simple but powerful analogy. It's like an electrical storm. See, our brain runs on electricity. It's this massive, beautiful network of electrical signals zipping back and forth. A seizure is basically a sudden, chaotic surge in that network, a brief storm of uncontrolled electrical activity that messes with normal brain function. The words to really hang on to here are transient and brief. This isn't a permanent thing, it's a temporary event that passes.
Okay, and this is a really critical fork in the road, because it turns out not all seizures are the same. On one side, you have a provoked seizure. Think of this as the brain's normal reaction to a totally abnormal situation, like a super high fever, a major head injury, or a big chemical imbalance in the body. Then, on the other side, you have an unprovoked seizure. This one happens without any obvious immediate trigger. It suggests that the brain itself might just have a built-in tendency, a lower threshold for these electrical storms. And figuring out which one it was, that is absolutely key.
And here's a fact that might help you breathe a little easier. Even though it can feel like an eternity if you're watching one, most seizures are self-limiting. They stop all on their own, usually in under 5 minutes. Now, a seizure that lasts longer than 5 minutes is a different story. That's a medical emergency, and it's called status epilepticus. So, the electrical storm is past. You find yourself in a doctor's office, or maybe the ER. What's next? Well, this is where the detective work begins. Doctors and specialists start piecing together all the clues to figure out what happened, and more importantly, why.
After a first seizure, there's a pretty standard playbook. It's not just one test that gives you the answer, it's a whole process. It always starts with the story of what happened and a physical exam. Then they'll do blood tests to look for any of those provoked causes we just talked about. And from there, they start looking directly at the brain's function and its structure with things like an EEG and imaging scans.
And I really want to pause on this because it's so important. With all the incredible high-tech gadgets we have today, you'd think the most valuable tool would be some fancy machine, right? Nope, it's the story. What the person felt right before, what a witness saw during, and how the person felt after. That detailed account is the absolute cornerstone of the whole investigation. The EEG is kind of like an EKG for your heart, but for your brain. They place electrodes on your scalp to just listen in on the brain's electrical chatter. And here's the cool part. They're not necessarily trying to catch a seizure while it's happening. They're looking for specific little blips and patterns between seizures that act like a fingerprint, a sign that the brain is more prone to having another one. So if the EEG is about the brain's function, what it's doing, neuroimaging is all about its structure, what it looks like. An MRI or a CT scan gives doctors a picture of the brain itself. They're looking for any physical reason for the seizure, like a scar from an old injury, a tumor, or maybe a part of the brain that didn't form quite right. Finding something here can really change the game. All right, all the detective work is done. The test results are in. Now comes the most important part of the whole journey. Putting all those puzzle pieces together to make a diagnosis and figure out what to do next. This is the million-dollar question, isn't it? After a first unprovoked seizure, this is what's on everyone's mind. And the answer, which might surprise you, is usually no. But to really get why, we have to look at how we even define epilepsy today. So this right here is the modern, super practical definition. See, epilepsy isn't just about having had seizures in the past. It's about having an enduring predisposition, a lasting risk of having them in the future. For a long time, that meant you had to have 2 or more unprovoked seizures.
But now, you can actually be diagnosed after just one, if the tests show that you have a really high risk, specifically over a 60% chance of having another one. It's a diagnosis based on future risk, not just on past events.
Let's put some numbers on this, because it makes it all make sense. After one unprovoked seizure, your risk of having another one is about 33%, or 1 in 3. That's why doctors often say, let's watch and wait. But after a second unprovoked seizure, look at that jump. The risk of having more skyrockets to over 70%. That second seizure is a huge predictor. And that's exactly where that 60% rule comes from. The thinking is, if someone's risk after just one seizure is already as high as someone who's had 2, it makes sense to call it epilepsy and start talking about treatment right away. So, let's say the diagnosis is made, and the decision is to start treatment. The good news, the really good news, is that we are worlds away from those ancient days of mystery. Today, we have a whole toolkit of really effective options.
You can think of modern treatment as being built on 4 main pillars. For most people, the foundation is anti-seizure medication. These drugs basically help calm down that excess electrical activity in the brain. For others, especially kids, special diets like the keto diet can work wonders. And when meds don't quite do the trick, you've got these other amazing options: surgery to remove the one tiny spot causing the seizures, or even implantable devices that use electricity to control them.
And those other pillars are so important because while medications work great for most people, about 30% of people with epilepsy have seizures that are resistant to drugs. For that group, things like surgery and neurostimulation aren't just options, they can be absolute game changers.
I mean, this stuff is straight out of science fiction. These devices work kind of like a pacemaker for the brain. Some of them deliver tiny, regular electrical pulses to make the brain less likely to have a seizure in the first place. But others are even smarter. They actually monitor the brain's activity in real time, can detect the very beginning of a seizure, and then send a targeted pulse to shut it down before it even starts. It's incredible.
Okay, we have covered a ton of science and treatment, but that brings us to our final and maybe most practical section. This is all about knowledge that everyone should have, whether you have seizures or not. Knowing how to help someone safely is a skill we can all learn. The goal here is super simple. Just keep the person safe and comfortable. You're not trying to be a hero and stop the seizure. You're just trying to prevent them from getting hurt while it runs its course. So you roll them on their side to help them breathe, cushion their head, move sharp objects away, and time it. And just staying with them until they're fully awake and aware again. That part is just as important.
If you only take away 2 things from this part, please let it be these. First, just stay calm. Your calm energy helps everyone. And second, and I cannot say this loud enough, do not put anything in the person's mouth. It is an old myth that someone can swallow their tongue. It's physically impossible. Trying to shove something in their mouth can break their teeth, injure their jaw, or get your fingers bitten. Just don't do it. So there you have it. We've gone from a single, frightening event through a whole detective story of an investigation to a place of real understanding and effective management. What was once seen as some kind of mysterious curse is now understood for what it is: a manageable neurological condition. The progress we've made is just mind-blowing. And all that progress leaves us with one last, really fascinating question. As we get better and better at mapping and treating these electrical storms in the brain, what else are we learning about the fundamental workings of the brain itself? What new frontiers about consciousness or memory or thought are we going to unlock next? It's just a great reminder that every challenge in medicine is also an incredible opportunity for discovery.